Cheers.
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 And welcome to the Afternoon Pint. I'm Mike Tobin.
I am Matt Conrad.
And who do you have with us today?
My name is Andrew Travers.
Andrew Travers.
Dr. Andrew Travers. And
welcome to the show.
Why do you have a deck of cards with you?
Matt, it's one of the things which it's a tradition in terms of meeting patients or new friends and that kind of stuff. We always start off with a card trick and stuff like that. And so what if I can bear with you for a minute?
A card trick.
A card trick. And so
The first card trick on our show ever.
and
I
it's
don't like
one-
magic.
If you just move your phone for a second.
Let's try it.
All right.
Again, you're going to be checking your wallets after this. So there's 3 calls into 911 for an emergency and stuff.
Okay. So 3 cards for our listeners. 3 cards are now placed face down in front of us.
All right.
So there's the first call that we see, the second call, and the third call. All right. So there's 3 patients, a 4-year-old, a 9-year-old, and an 8-year-old.
Okay.
They're all okay, but the 4-year-old, 9-year-old, 8-year-old.
4 is of diamonds, and the
Don't worry about the suits.
9 and 8
They're all
of the
red.
heart variety.
4
I just want to make sure our listeners know in case they're getting duped
9,
here.
4, 9, 8.
Oh, okay.
So watch my hands really closely. There, I just did the trick. This one here, what card is that one?
What was it? 4?
And the middle one here,
9?
and this one here.
8?
It ain't. So 498, 894. We send out the ambulances to pick them up. The ambulance went out to the first case, picked up these 2 patients. Which patients are in my hand?
The 8 and probably the 4?
Exactly. So
Right.
what's this one here?
Should be the 9.
Take a look. See, this is the best part.
Oh, there's a queen of spades there. That's
I know,
nothing like
but
what
see,
was there
the deal
before.
is that 24 hours from now, anytime we cross paths, if you bring a joker from a card deck, I keep the joker, and then you keep the card trick, and you can show it to anybody you want. But you have to keep that tradition going forwards.
Okay.
That you
All
wait
right.
24 hours and you get to trade what you want to trade it for. So beer, coffee, wine, errands, that type of stuff. But so literally over the course of the past 15 years, we've had thousands of patients, residents, medical students, paramedics,
Yeah.
nurses in the comm center, nurses at telehealth swinging by saying, "Oh, dear sweet Jesus, you ran into Andrew. Did he torment you with a card trick?" So
All right.
Cheers to that.
I
I don't understand card tricks. I'm not. I don't spend much time looking into card tricks and stuff. Do you, Matt? I know very
The
little.
occasional. I mean,
Yeah.
I don't know really any.
just for your listeners that are out there, both of them were just checking their wallets as they were just talking here, making sure that their wallets were intact. So.
I am missing a Tic Tac.
Just one tic-tac.
Just one. Yeah. So, Andrew, you're a medical doctor, Nova Scotia native. You completed your undergraduate at Dalhousie University, pursued a postgraduate in epidemiology at the University of Alberta, fellowship of training in emergency medicine with the Royal College of Physicians and Surgeons in Canada in 1999. Currently, you are the professor attending medical staff in the Dalhousie department, and my gosh, there's like 100 other things here.
I've been lucky.
You've been lucky.
I'm blessed.
I don't know if that's lucky. I think that's a whole lot of hard work.
You've been busy.
The thing I'm most proud of is that I'm the son of 6, a husband of 1, and a father of 2.
Oh, wow.
And but one of the things I'm also very proud about is that I have the best job on the planet. I get to work with an incredible team of paramedics, nurses, and docs as the medical director for EHS, and that's my full-time gig.
Wow.
So
That's awesome.
I'm going to tell you how we made our connection. So my friend Rob, he was a paramedic. I met Rob probably in our teens. When he was in his 20s, early 20s, I read a book by Joe Connolly. It was called Bringing Out the Dead. And it was about a guy as a paramedic in Hell's Kitchen. Okay? Long story short, the book was amazing read, but mortifying. It wasn't totally based on reality, but it was based, this guy was an ambulance driver before he wrote the book, and it had a lot of spiritual stuff incorporated into it. It was a really interesting read. And then when the movie came out, Rob, my buddy, I showed him the movie. I was mortified, and he was like, "Wow, that's awesome."
Yeah.
And he decided to be a paramedic, and I thought it was the scariest thing in the world.
Was it because of the movie?
No, it wasn't because of the movie. He was already on his way. But when I watched the movie, he was like highly endorsing of it, like, "Oh my gosh, this is really great." And I was just like completely like, "Oh my gosh," like horrified.
I see Rob Groom, I see Nicolas Cage. One and the same in many ways.
Nice.
100%. Yes, I can't disagree with that.
Listen, I read this and Bringing Out Your Dead, and I immediately went to Monty Python and the Holy Grail and was like, "Ding, bring out your
geez.
dead."
Well, I guess my question is stemming from that, though. It's like, so, I mean, there's some people that pursue a medical career, and there's some people that don't. My partner, again, likes the biology of things, of us, and I'm mortified by it, right? So what made you want to pursue a career in medicine?
I'm the youngest of 6. I come from a family of engineers on the boys' side.
Bunch of slackers in your family.
And nurses on the other and stuff. And so, again, being the youngest of 6, my middle name is Oops. And so I wasn't quite sure which path I was going to go on. Of all things, I was going to be a brewmaster.
Oh, really?
Wow. My undergrad was in microbial biochemistry, and I was going to work at what used to be the distillery on Windmill Road. That's now an office interiors location. That used to be a brewery, and it was just a fascinating thing of saying I'm going to be a brewmaster. As I got towards my 4th year in undergrad, I had a kind of a light that went off and said, I think I'm going to go into medicine. And when I went to medical school, I fell in love with emergency medicine, but then I switched gears, orthopedics in 2nd year, urology in 3rd year.
Wow.
It was my focus, but in my final year of school, and you had to choose what you were going to do post-graduation, the happiest people that I saw were people that were in emergency medicine. And it's thanks to paramedics that the old VG emerged. When I was walking through in my first year, and over my years, it was paramedics that welcomed me into a family, and that had a big impact on me. And so emergency medicine is what I chose. And I'm learning from my paramedic peers since 1994.
Wow.
That's why we call it a practice. We never get it right. That's why docs always use the word practice. So it scares patients when you say practice. You know what I mean? You're still practicing.
So the answer's beer.
The answer's beer, yeah.
Beer to medicine.
Listen, I think they're one and the same. I think beer makes Guinness's slogan for a long time was it's good for you. Beer, it's good. Guinness, it's good for you.
It's also a source of a lot of patients that we see in the emergency department. So it's
probably that too. Yeah, that's fair.
Yeah.
You know what Homer Simpson
some new
says?
studies that
wise,
conflict that, Matt.
What's that?
There's some new studies that conflict that.
No. The wise words of Homer Simpson: alcohol, the cause of and solution to all life's problems.
Yeah.
So yes, but yeah, no. We had a quick little chat about this being over in the UK about how the pubs are attached to hospitals over there.
I don't know how they pull that off, but I remember when I was a student in early residency, people would be doing electives overseas, and they'd be doing the rotations in hospital, and then in between rounds heading to the in-hospital pub. And I always thought that was really interesting that they had that type of thing, but also you could smoke a pipe in said pub, and I guess that only in the UK could you have something like that, pull it off the ground, but nevertheless, there was no such similar kinds of things within the Canadian healthcare system.
No. Too bad.
That's too bad. I don't know. I think the Nova Scotia is due like we have schoolhouse and things like that and everything for themed church brewing. So it's like where's like the medical themed brewery?
Oh right? My goodness, that
like we could do blood donor Irish red or something.
No, I was just thinking it's the color of the beer.
Triple bypass IPA.
Triple bypass IPA.
Yeah.
Nice.
Yeah.
There you go.
But the colors too. It'd be maybe not the most appetizing beverage that's out there, but you could match the color of the beer to the bodily fluid that.
Oh, there you go.
Oh, yeah.
Yeah, he's going to ruin beer for us.
Yeah.
Oh, shoot.
We'll switch to martinis.
There you go. Yeah.
Nice and clear.
So I guess today you are the director for EHS, Emergency Healthcare Services. Is that correct?
I'm part of a team. So think of it this way: anything to do with health or clinical care when someone contacts 911, I get to have a hand in it. So whether it's the back of an ambulance, back of an airplane or a helicopter, or our teams that are out there, anything to do with health when you call 911, I have the good fortune of working with teams that help provide care.
Right on. And do you find, just high level, do you think the last few years have been challenging in certain ways, or immensely, do you feel the last few years have been, I mean, I'm not going to go back to COVID, but just within the last few years of after COVID, kind of getting back to normalcy? I
think, I'll be honest, every year that I've had with the system, I think has been better than the previous year.
Yeah.
Okay.
I've been incredibly proud. I'm excited about what happens when you call 911 in Nova Scotia. At the end of the day, your care begins when you call 911.
Yeah.
And I think that's important for Nova Scotians to understand, and that the exciting part is that 30 years ago when EHS started, if you called for 911, it always meant an ambulance transport to emerge. And if you call 911 now, transport is ancillary. It's not mandatory. And we can figure out things, do something different, but it doesn't necessarily mean a transport to the emerge. So we're doing more and more of that this year than we did last year. And last
That's
year
the
we did more of it.
IHF program, is it?
It's everything.
Yeah?
Yeah, so it's not just the IH, is the integrated health programs, but that's just one piece, one of the tools. A lot of times that people call 911, it's the worst day of their life, and that type of thing, and we're able to kind of just ask more questions. And then sometimes that call then is answered by one of our nursing colleagues in the comm center, and we don't even dispatch an ambulance.
That's
and
great.
we plug them into a different pathway, or we do dispatch somebody, but as the ambulance is going there, they're speaking to one of the docs or the paramedics or both as the ambulance is responding. So, I mean, that's just cool.
Yeah.
It's so cool that that's now happening.
So technology has majorly helped thus far in kind of making those connections happen as well.
Yeah, and technology. Everyone's got a smartphone, so now we're using video. It's called text to video. So some of the patients we're having contact with, we're on the phone with them and we say, you know what, you're describing things really well. We're going to send you a text message right from the comm center. They click on it, don't have to download anything, and then we've got a video connection. And so they're like a Spielberg on scene, and they're kind of controlling the camera and showing their the cut and saying, do I need to go to hospital to manage this cut or this rash or whatever it turns out to be? But we've been doing that for almost 2 years.
And do you feel like that is going to be, like, continuing to do that work is going to be the biggest thing in terms of, like, because, I mean, obviously the burning question is ambulance wait times, right? Do you feel like that's going to cut that down?
Yeah.
Yeah?
Yeah, I think just...
Have you seen that over the last couple of years since you started doing this?
I think absolutely. I think the more important measure is you don't measure success by how quick an ambulance get to someone. You measure how quickly someone got care.
Yeah.
So I think that's the change that we're looking at now. So we always ask people to say, okay, don't measure the response by whether or not you saw an ambulance driving down the street or arriving on scene. Think about what was the interaction between the caller, the family member, the next of kin, whoever's on the phone, speaking with someone who's actually listening. And so your time to nurse is faster. Your time to a physician assessment is faster. It's just different in how we're doing it.
Yeah.
Right.
No, that makes sense. Yeah, it's not really that different than how we have to revamp and how we think of healthcare in general at this point. Like whether you're using pharmacists for things or using nurse practitioners and things like that, right?
Right.
Some of the recent changes that we've seen in the last 2 years.
Absolutely.
And every bit of the problems is slightly different. So some of the tricks are, okay, you know what, for you live in a rural part of the province and you may not have much access to resources. And so you have to think outside the box and pivot and say, okay, maybe we're going to do some structured follow-up with your local pharmacist. But again, the key thing is just that during that worst moment in someone's life when they've called 911, that you're able to just have more of a conversation, unpack things, and even sometimes it's like, that's okay to wait, or you should go into the emergency department, but it doesn't have to be by an ambulance. Maybe you're good to go on your own, you're clear to go on your own, and tell you what, we're going to be on overwatch from your home to hospital. And not to sound paternalistic, but just send a text message when you get there and make sure your eye's safe. But if there's any problems from this point forwards, know that there's someone in clinical overwatch watching to see if anything unfolds. So again, I think that's what people want. Within the provinces, just they want some answers. They want to know if they're going to be okay. And if they have a plan, it's like, oh, that plan's perfect. You're going to get to care faster and in a safer way if you begin moving now as opposed to, say, waiting for an ambulance, because even if you ride by ambulance, it doesn't always mean that you're fast-tracked through the emerge faster. It's quite often we'll actually just drop you off at the front door and you go into the waiting room.
I think that's a common, like, misunderstanding that people seem to think that if they go in by ambulance, they're going to get seen first.
Yeah, it all depends on severity. And so if
People still think that, you think?
I'm pretty sure because I think so. Yeah, I've heard people say like, well, I'll just go home and call an ambulance. And I heard it, like someone at triage say like that we still triage you.
Wow.
Yeah.
Yeah, that's terrible. I mean,
but
not good.
Yeah.
But it's good though, so that's how the system's integrated. So that we as a system work with our health partners to make sure everyone's getting the right care at the right time for the right reason in the right place. Lots of rights there.
Yeah.
Type of thing, but it's one that it does work well. So just people should rest assured that if they're sick,
So
EHS health, we're going to get some care to you.
going back a little bit, like what is IHF to someone that doesn't really understand it?
I think the word that we've used is IHP.
Sorry, IHP.
Yeah.
Okay.
So you got me stuck in the IHF part. Sounded like something like a Mission Impossible movie and that type of stuff. It's the villain's IHF.
Oh, I mean, anyone's listened to this show before, as I struggle with acronyms to a fault. So no one will be surprised if they're coming back to listen.
Yeah. He's gonna be calling you something else. It's all right.
Yeah.
No, so the I is integrated and the H is health.
Yeah.
And then it's a program for integrated health programs, and that's where it's a cluster of people, a group of people, medics, nurses, and docs doing things differently. But also it's the IHP medic, the integrated health paramedic. And that's like Rob Groom, the person interviewed, was one of our first kind of IHPs. And they're woven through different areas. There's these paramedic Jedi that are either in the comm center or they're in non-transport capable ambulances called single response units.
Oh, cool.
But these paramedic Jedis that are out there are doing things a little bit differently. And I think whether it's an integrated health program or it's integrated health paramedic, that's the secret sauce, I think, going forwards. We're going to do things differently.
Was that practice brought in from like other parts of the world, or was that come in from here? Like, was that innovated here?
It innovated here, but also learned from other places. And so it's a bit of a blended model. Our very first integrated health paramedic would have been a paramedic that was in like the communication center, dedicated for providing clinical decision support. There's always been paramedics in the communication center, but one focused entirely on clinical help, and that began a long time ago. And then the next integrated health paramedic that came out was a paramedic who responded to long-term care facilities. And they kind of brought the emergency department to long-term care facilities to keep seniors safe at home, suturing, providing antibiotics, those types of things. So those were innovations kind of born in Nova Scotia that other provinces, other countries are saying like, wow, that's really cool. We should be doing that here. And then we started learning from other places about that mobile integrated health paramedic. So these people that would be out as single providers, kind of roving, and there's a few places within North America and elsewhere that's doing that. I'm always hopeful we can get EMS motorcycles and that type of stuff. But again,
cool.
People listening to say, oh, geez, you said EMS motorcycle.
Why an EMS motorcycle? I'm curious.
I come from a motorsport family, so I married into motorsports. I've been extremely lucky. My wife got her motorcycle license well before me. I know it's a conflict of interest being an emerge physician, but being a motorcycle fan, but I can't help it.
Yeah.
We don't have motorcycles yet for our paramedic Jedi, but maybe someday.
That would be kind of badass. You just have like all your medical devices on like saddlebags.
They put the siren on top of his helmet.
I think
Like, woo, woo, woo.
like Inspector Gadget.
you've been to the UK.
Man, oh man, that's great.
Yeah. So I think you know what? Listen. So if anyone's listening, give some investment there. Premier Houston, like let's get some investment in some motorcycles.
No, we've been incredibly lucky that all forms of government have been incredibly supportive of us moving the needle forwards. And I have to thank someone who isn't with us anymore, but Ron Stewart. Ron Stewart was the...
You're reading it right off the page. You're beating me to my own notes.
So Ron is still here. He is the S in EHS. Ed Kane is the E in EHS. These are the kind of forefathers that kind of created EHS. And so we've been really fortunate. That's the reason when you ask about, how are we now post-COVID? We're in a really good place. Yeah. I think it's really exciting. I think there's lots of people.
I don't feel like that's the public perception. In fairness, if I talk to 5 people a day, they're like, "Oh man, I was in the ER for 6 hours because when I broke my arm," and they'd be,
You'll be in the ER for longer than 6 hours if you just broke your arm.
Yeah.
But I can share with you a vignette. I'm one of the docs in the box, doc in the comm center, and I was working there on Sunday, and there was a patient who called in from Nova Scotia for her mother.
Yeah.
And it was a 911 call, and it was for the person having some pain in their mouth, some dental pain, and they were terrified. And so they called 911. We do what's called secondary triage, where we'll call patients back and stuff. And we spoke with this daughter and her mom and put it on speakerphone, and we then unpacked things and simply had a conversation about, okay, what's going on? Here's what we can do. and use that Good Sam video to kind of look and have an examination of kind of the tooth that was bothering her.
Yeah.
And usually what happens when people call 911, they would say, don't eat or drink anything until the paramedics get there. And we're like, okay, paramedics, we can get them there, but let's try these things and come up with a plan. 15 minutes we were on the phone call with this patient, and by the end of it, they were both happy. They were pleased. They had a plan. We de-escalated a whole bunch of things, and we came up with a safe care plan kind of going forwards. And it was all done in, we weren't changing their wishes of calling 911 and expecting to go to hospital. They were calling 911 saying, I need some help.
Right.
And I can't explain what's going on. And the daughter says, how long have we been doing this? And it's like, we've been doing this for 4 years. It was our 4-year birthday of having like a doc in the comm center. And it's like, why haven't we heard about it? And it's like, well, it's one where we don't want people, calling 911 when it's not an emergency. We still want people to pay attention to their instincts. But for me, that's a success. And I wish you could just bottle it up and then show that comfort that's provided to people in their homes when what began as the worst day, which prompted them to call 911, ending in something which is really positive. And I'm really lucky. Every time I'm in the comm center, I have a story like that, story after story after story.
Amazing.
Yeah, it just goes to show you that like people are gonna go with their feelings and kind of how they feel at the time, or whether they're listening to good information or not, or whatever, right? Like I said, if you're going to go to the emergency, you're going to sit there and wait for longer than 6 hours. But that being said, you probably should. I mean, if I played football and I've had many broken things, and I've sat in the emergency for a decent amount of time, 8-10 hours sometimes, for broken things. But that's not an emergency. I need to be at the hospital because I need to get x-rays and I need to get cast. I can't go to my family doctor for that, but I'm also not having a heart attack, and I'm whatever, right? Like,
but it's a great point. I think everyone defines their own emergency and stuff like that, and I think it's what we're there for. If people are in a pain crisis, they're in a crisis, and so we never want to talk people out of paying attention to their instincts.
Yeah.
And that's one of the common things that you'd always tell people when I was in the emergency department as an emerge doc was, we're going to send you home, and here's the instructions, and pay attention to your instincts. If you can't explain what's going on, then that's what we're here for. And it may be frustrating, it may be long waits, and it may be doing something different and that stuff. But I'm really proud of both our emerge colleagues and the EHS system saying we can do things, we can maybe do things differently. And I think that's where we're in the change right now.
Cool.
Yeah. And I mean, how about like avenues like 811? Do you find those are being well utilized today?
Absolutely, and I think that's that connection of how do things flow from an 811 system into a 911 system, 911 into 811, back and forth. It's really just predicated on communication and using the right words and being there in the moment when someone's talking, letting them talk, and noticing the signal that's in that, what maybe noise to you or conversations as to what's going on, and then making connections and stuff. But I think it's not just between 811 and 911. We make referrals to 211 a lot.
211? What's 211? I don't even know.
Well, this is a
Should I know?
This is a hidden gem.
There's 311. There's 211.
Gosh,
there's 911.
there's too many of them.
There's you call 511 for the weather.
Yep.
And then
I didn't know that was the thing.
But this is for me. When I was in the emergency department, I used to have a social worker.
Okay.
Who would be there to help with things on discharge from the emerge. As a comm center physician, 211 was our proxy for it. So we may have medics that are seeing someone saying, I'm seeing a senior. It's the 5th time we've seen this senior this month for falls and stuff. But she never wants to go to hospital. She has capacity. We're coming up with safe plans. In some areas of the province, we make a referral to a falls clinic right from the paramedic's assessment. But part of the discharging plan we do with the medics is saying, we'll have her contact 211 because she may get some supports for some aids, some ambulation aids.
Okay.
If there's people that we see that have needs for food or needs for navigating some systems, I don't know how to take steps towards getting power of attorney on my father who is showing some signs of Alzheimer's or has been diagnosed with Alzheimer's. I don't know how to navigate that. a number of these things, this is where that resource like 211 is really helpful. So I think as patients call the system, we have all of these agencies that can work together differently and collaboratively, all focused on.
So you'd call 811 and say, okay, my father's showing kind of scary right now. He doesn't know where he is. This type of scenario, and you'd call 811, and they might end up putting into 211 depending on how they survey you. Is that how it would work?
I don't know from the 811 side specifically in terms of protocols, but the illustration, I wouldn't be surprised if someone called in and said, my family member is acting differently. Mm-hmm. That's appropriate for the kind of 911 side, saying, okay, was it acute change or not? So I wouldn't be surprised if it would come over. But that doesn't mean an emergency department visit. It means, okay, maybe what we're going to do is we're going to have one of our team reach out, and it could very well be the nurse in our comm center reaches out and says, tell me more. We have all the time in the world, but let's unpack this and stuff. They get information. And they may make the decision saying, you know what, I think this patient's going to benefit from having a set of eyes on them. Maybe just make sure his sugars aren't low, make sure his vitals are okay. So we're going to send out one of our paramedic Jedi, the single response units, out to it and stuff. And now they're eyes on scene. And now they're actually evaluating the patient, and they then call back and speak with the doc in the comm center. And they say, okay, what are we going to do? And then this is where the team, the medics on scene, the nurse, the doc in the comm center, take this and say, all right, here's going to be the plan. We're going to give the following information to the caller who started everything, saying, all right, here's the plan. We're going to maybe have you contact 211 for kind of next steps with things. We're going to get you to look at the EHS special patient program so we can get your father enrolled into it, so we can have a case-specific tailored plan for your dad in the event of a 911 call, kind of focused on keeping him at home or keeping him managed.
That's brilliant.
But this is the idea. It's simple. It's just people talking without rushing through things or having a knee-jerk
It's just
response.
people communicating with each other and listening deeply to kind of get to the core of what a problem is.
The colleague of mine, Jeff Fraser, gave me this beautiful quote 20 years ago, and he said, Andrew, the 911 system of old used to be that there was, we were looking through the peephole of a door, a keyhole of a door. It was short, it was constrained, it was limited, it was a 90-second or 2-minute health assessment, but all you could see was what you could see through the that little keyhole. Where we're at now today with the teams in place and all of it is we've opened the door.
You're seeing an entire 360
You're seeing,
image.
We've opened the door, and whether the patient's coming to us or we're going to the patient, the door's open, and it's all built on communicating.
Wow. Pretty cool.
It's awesome.
Now that I understand, the mechanisms to work behind in the background.
The next step, we'll just make 9-1. It'd be faster to dial, just 9-1.
Please.
I don't know.
Just help.
I don't know. You might have more
Pocket misdials.
More misdials. Yeah.
I've been guilty of those.
Yeah, exactly.
So dear Travers is calling again.
So I know there was a question you had there in that you wanted to kind of ask about. You had a good one here where it says you have a lens of emergency and pre-hospital care. So if you want to ask that.
Oh, go ahead. Ask
it.
Read it.
So how has the lens informed what you think the system's strengths and liabilities are? So I guess kind of give us an idea of this is what it's really kind of made the improvements on, and this is what we kind of need to really work on because this is where there may be some gaps.
I think the improvements is that we have empowered paramedics to practice to way beyond anything in many ways compared to other places. Nova Scotia have faith in paramedics. That's why they're self-regulating.
Yeah.
What there's the implementation of a college. I think they, as clinicians, are fantastic. And I'm honored to work with them. I think that is one of the successes. And everything we do in EHS is thanks to the paramedic professionals that are out there. I think the liability, the risk part is sometimes we're victims of our own success. And we can help things, but then we have to be cautious on everyone then relying on the 911 system, on the EH system to fill in the gaps.
Yeah, like not having a family doctor.
Right.
And things like that.
And it's the idea is saying, we always be cautious on saying, I'm going to call 911 because I need a prescription refill for my blood pressure medication. Now, it may be that they're terrified. I'm really worried about it. It's okay, so maybe what we're going to do, we're going to take that 911 call and we're going to plug you into the virtual care options that
Like
the health authorities
Maple
put
or
in.
something like that,
Or it's called VUNS, which is a virtual urgent care Nova
I didn't even know
Scotia.
about this. Okay.
But these are the illustrations of kind of just asking more questions and having a rational conversation and plugging that in to a different pathway. Even with that liability of saying, okay, I don't know what else to do, I'm lost, so I'm ending up calling 911. I just think it's that's where the area of risk are, where they maybe filling in some gaps which are not in the original kind of with the premise that really wasn't a 911 call to begin with.
Right.
Again, we'd always tell Nova Scotians, rely on your instincts. You know your body and that stuff. So we're never going to talk to people at 911 call. We just want to provide different pathways.
I got a not so intelligible question, maybe. Are you charged if you call 911 you shouldn't have? Like, don't
No.
you get a charge?
No, so
Well, I thought that for some reason in my head. I thought if
No.
you like called it for like whatever, and it
You might
was
get
like
a visit by the police.
no, but if you called it and didn't like it wasn't for a good enough reason, I thought you got a charge. I don't know why I believe
If
that.
you were prank calling them, maybe yes.
no, so it's a great question.
Yeah.
So there's only an ambulance fee if you're transported to hospital.
Okay.
And so the reason for that is multifactorial. It's one of the big things at a federal level is that the Canada Health Act doesn't consider an ambulance transport a medical intervention. Doesn't make any sense.
Wow.
So every province has ambulance fees tied into it. So it's federally that needs to change at the Canada Health Act. So
Like
they can have,
$250 a trip, isn't it? For a little more?
$750 in a
Is it
car
$750 a
accident.
trip?
no, it's $140-ish
Okay.
for an ambulance transport.
But I'm pretty sure, wasn't it like in the event of a car accident, it's like $700 or something? Like
Yep, and for a
Yeah.
car accidents, I'd refer your listeners to the website because I want to make sure I'm not getting the numbers
Yeah.
correct. But yes, when there's third-party billings like an insurance company,
Right.
then there's a higher related cost. But relatively speaking, it's not like someplace in Canada where they charge both an upfront cost and a per kilometer cost. It's very expensive.
It's like Uber.
The U.S. costs
But-
nuts.
No, oh, I bet.
I learned about that one day. I was like, whoa.
This is where I'm going to insert a quick little plug about buying travel insurance.
yeah.
There you go.
But
Yeah.
the important part though is if you're not transported, there's no cost.
Yeah.
And so one of the questions was, how often does a non-transport happen? So of all 911 calls, at least a third, more than 33% of calls we don't transport.
Wow.
Okay.
We treat and release. We follow up on these patients. We're doing things safely. We're playing different pathways. So 1 in 3 ambulance calls we don't transport. And that's the regular paramedic teams. The paramedic single response units, when we send them out, they have a 60 to 95% non-transport rate. Which means-
60 to 95?
correct.
That's
And
only 5% then, as low as, wow.
So
Okay.
it means that most cases they're not transporting, meaning there's no cost borne by the person. Yet they're getting treatment at home, a palliative care patient, so on and so forth. And so it's one, it surprises everyone when we tell them those numbers. We thought every call went to the emergency department. It's like, no, actually,
Yeah.
only, again, 33%. And it's been like that for a very long time. And the idea is we want to make those numbers even more efficient so that we can still do more treat and release, more treat and refer, I should say.
It's interesting because, I mean, like, because EHS is a private company.
No, so that's a common misconception.
Okay,
So-
I thought it was, yeah.
No, so EHS is a public utility model. And we're one of the only public utility models in North America, which means Nova Scotians own it.
Oh, okay.
So EHS is a section of government. That's the regulator.
Yeah.
And that's where I'm employed. I have a contract with the Minister of Health or within DHW. And EHS is that arm of government that oversees the clinical care protocols, the assets, the device, all those equipment and stuff, which are out there. And in a high performance contract, our co-lead is EMC. And EMC is the company that you're referring to,
Okay, 'cause that
which is part of Medivie. And so there's
Right, okay.
the best way of thinking about it is that EHS is the what, and that's government, and EMC is the how.
So I guess for anyone to understand, it's almost like kind of like Halifax water.
It's the way to describe it. That's why we use the term
Yeah.
public utility model.
Yeah.
And for us, as a public utility model, we've got a responsibility for healthcare.
Right.
But that's only one part of it. And that's like what happens during the 911 call. We have a responsibility, though, for public safety. That's the next 911 call. And we also have responsibility for public health and community health. And that's all the previous 911 calls that we can then use to inform things and work with our partners differently so we can keep communities healthy and safe. So those three things as a public utility model, healthcare, public safety, and public health are the main drivers. But EHS, is a wing of government. And
Okay.
that's where my office is located. I'm in the good fortune of working in the Department of Health here downtown in Halifax.
Wicked.
Pretty cool. I'm learning tons of stuff, by the way, so thank you so much.
Yeah, this is awesome.
This is
Very informative.
Yeah. I have another thing here. So that friend of mine, Rob, when I texted him early this morning, said, "Hey man, what should I ask this guy?" He gave me a couple suggestions, and this one I thought was quite interesting because I didn't know anything about it. But I guess the goal here, help me understand the quintuple aim in Nova Scotia. First off, what is the quintuple? How could that be described?
I'm going to murder Rob.
I have notes here. If you need
Rob, you are going to have to call 911.
If you could ask Rob what the square root of 72 is, there's going to be a big, long pause.
We can shorten this up. Don't worry about that.
No, I'm thinking with regards to precisely for what the quintuple aim is. And for those that are...
I guess first, high level for a lot of us are like me. We might not even. I didn't know 211 existed in this episode. I mean, what does that even mean? The quintuple.
Wow, you have graphs and charts.
Well, no, it just means it kind of depends in terms of which group you're talking about. The quintuple aim.
Yep.
There used to be that there was frameworks around. If you're providing healthcare, you could have it fast and good and cheap.
Oh, this thing. Okay.
And then you had to choose two of those three things. You could have it fast, good, it wouldn't be cheap. And then it kind of migrated, and people started using this quintuple aim of saying, all right, there's a few things there with regards to, there's a patient experience, population health, provider experience, equity, and the associated cost around things. Mm-hmm. I think whatever definition we're using for it, that has to be in the DNA of the EHS system. We need to be, everything we're doing needs to go back and kind of be tested against it.
How it kind of measures against those 5 pillars.
Right.
Yeah.
But there's one thing, if I can, just there's one, I'm a geek. You said at the beginning, like, say, Andrew, you did a master's in epidemiology and stuff. What does that mean? There's, for me, the quintuple things that we can do to improve lives of Nova Scotians is, there's 5 things we can do in healthcare. Everything that we do routinely is what we call secondary health prevention. Mm-hmm. What that means is people are already sick and we're preventing the disease from getting worse. They have a heart attack, we open up the blockage. They have a knife sticking in their chest, we take the knife out and fix things up. They have the disease and we're preventing it from getting worse by giving them life-saving therapies. That's the mainstay of what secondary health prevention is. But then there's these 4 other things we could be doing as an EHS system. I know this is really boring, but it's one of
No, it's not at all.
But the first thing is primordial health prevention, reducing the presence of risk factors.
Okay. Yeah.
Primary health prevention, reducing people's access to those risk factors.
Good example. I left a rake standing up one time in the garage, and then Andrea walked into it and gave a really big egg on her forehead right before she had to get her picture taken or something.
That's right. You put the
what I could have done is not had that rake there, right?
Yeah,
But
exactly.
preventively,
The primordial prevention would have been put that rake away.
Yeah.
The primary health prevention would have been, hey, Mike, watch out for that rake. The tertiary health prevention is getting people back to baseline.
Right.
Quaternary health prevention is spread medical error. So one of the questions is saying, all right, as an EHS system, we've got the quintuple aim that we can look at and make sure we're doing things. But in my world, the clinical world, are we doing everything we can for the communities that are out there? Mm-hmm. How we can use our data and that type of stuff to make communities safer. And
how would you implement, like a guy like me that leaves a rake? Well, that's a silly example, I know, but how would you implement something?
Well, we pre-filled the Darwin Awards form for you. Put that in place for the self-inflicted rake injury.
I almost took a drink there.
Cheers.
But I'll give you an illustration about trauma.
Yeah.
So one of the illustrations is that data from EHS helped inform legislation about ATV usage.
Right.
It helped then actually put legislation into limiting the use of ATVs by minors. Primordial health prevention was teaching youth on making sure, or putting mandates in saying you have to wear a helmet if you're operating an ATV.
You're seeing all these kids or whatever coming in the ER, and you're just like, my gosh, this could be prevented with just some
How
pretty
about
simple
like
measures.
I'm gonna go there.
Yeah.
How about get your damn kids vaccinated? How about that one?
Whoa, cool off there.
No,
No, it's
because like I saw a report recently that it was like
I heard it's on-
25%
I heard it's on the
of
decline.
Nova Scotians don't vaccinate their kids
25?
for measles. 25%.
Ew, I didn't know.
And
that.
I was like,
Yeah, that's a scary thing. Yeah, you're right. I agree.
Your temporal artery is throbbing there. I can see that
Oh, yeah.
pulsating.
Oh, yeah.
So.
oh yeah, like parents who don't get their kids vaccinated, it's just like they're like, oh, but like before they da da da. I'm like,
All
yeah,
right.
before kids died at the age of 2.
I don't disagree,
Yeah.
but we're going to move on.
So just with regards to that quintuple aim, I'm a fan of it, but I'm a bigger fan for the 5 things we can do to every single community
Yep.
to make things safer for it.
So one is kind of look and see what's happening. What are the biggest problems in communities that bring the most people to the ER or causing the most deaths or injuries? Or
Well, let me give it one other quick example: opioid use disorder.
yeah,
So that's rampant right across Canada.
Yeah.
What has EHS been doing to try to help out to minimize the risk of opioid bad outcomes? Primordial prevention. We use a program within our system here to identify when synthetic opioids first arrived within Nova Scotia, and we use what's called First Watch. But data in the communication center that could help inform where some of these hotspots were. Primordial health prevention. Anytime a paramedic is in the back of the
so you're
ambulance.
basically saying, sorry, like, so people come in the ER, you're getting the postal code or whatever, and now you're seeing geographically
No,
all these
that-
folks that are overdosing.
No,
and stuff. No?
upstream.
Sorry.
During the 911 call,
Yep.
there we have programs that sit in that pay attention to certain words that can be found. It's like Shazam on your phone, and it's called First Watch. We use it for syndromic surveillance. But a simple idea of if we put some things in, we want to know when carfentanil entered the Nova Scotia system. So we put in the term carfentanil. Or during COVID, if there was ever any diseases that were happening where there was clusters of things during the 911 call, it would help identify these hotspots. That
Right, okay,
that
good, yeah,
intel can
yeah.
then be used with other agencies to help identify hotspots, reducing the presence of risk factors in the community. The primary health prevention is when a medic is with somebody and teaching them about an overdose, advocating for them, saying it's okay to go to the emerge or whatever. Secondary health prevention, we have these naloxone kits and how to manage opioid emergencies. Tertiary health prevention is helping that overdose rehabilitate back. Maybe they're not transferred to the emerge, but giving them a naloxone kit again, plugging them back in, advocating for them. And quaternary health prevention, the last one, the 5th one, is the whole idea of looking at errors. A senior citizen who is misdosing her medications, taking too much of a narcotic, our medics are picking that up. And so being able to identify that, flag it with the pharmacist or flag it with the patient or the family member. So the illustration is we're measuring success of our EHS system by adding to all 5 of those domains of kind of health prevention, primordial through to quaternary. Now, I know all the epidemiologists that are out there going like, rock on, Travers. I'm so excited because you're talking about epidemiology and health prevention. But that's the epidemiology geek in me, more so than the quintuple aim.
100%, yeah, and I mean, and there must be health factors you see in your field as well, where preventative health measures, like just on a high level from what you're eating, what you're doing, are you exercising? I know these things sound contrived, but they probably make a tremendous difference.
It does. The question which I used quite often in Emerge was, "What were you thinking?"
Oh, gee, yeah.
That caused it's like, "Oh, you're right. I shouldn't have walked into the rake as I was walking into the house in the middle of the night, having left the rake out there."
Yeah, no, get it. Yeah, 100%.
So we have some questions on these pillars.
Well, yeah, I
Specific ones?
mean, some of them we kind of
Yeah, you
really
did go through
talked.
some of them,
I mean,
yeah.
you really touched on a lot of this. Kind of going back to this quintuple aim thing. So some of the pillars that they talked about were things such as patient experience, which we really touched on a lot already today. I think, especially in the fact of how you're relating it through different parts of the healthcare system and stuff. I think that's great, right?
I hope the patient experience is positive,
Yeah.
and that their experience isn't defined by an ambulance rolling up, but their experience is being defined by what's happening after the conversation when there's call 911.
Okay, and then I guess the next one here, like one in population health. So we kind of just talked about that very briefly. With being healthy, obviously will have a tremendous impact on how many people go to the ER. However, we also have an aging population in Nova Scotia. So that will eventually, at some point, probably put more of a strain on the industry. I mean, are there issues like that that kind of keep you up at night right now that you think, oh, gee, we have to be prepared for what's coming in terms of this or that?
Yeah, absolutely. That population is a very exciting one to work with. Keeping seniors fit, keeping them at home, is one of the whole mainstays that we've been doing with an illustration of a senior who has a fall, referring them into a falls clinic. Again, right from the scene by the paramedic without having to transport to hospital. Through to the other end of, we have programs which was Adopt a Senior, where paramedics, the integrated health paramedics, would follow up in seniors out in the community. Dr. Judah Goldstein, who's a primary care paramedic, PhD, who's one of our research leads in the province, his specialty is pre-hospital geriatrics. Wow. He is a world-leading paramedic researcher on how we can improve the lives of seniors in the province. So it's not going to be a challenge. We welcome it, and this is going to be very exciting for people to have generations of good health within Nova Scotia.
It's a great answer.
Yeah.
Yeah. I mean, and I guess another one, I'm throwing these out pretty quick, and I do.
You're being kind of, listen to
have a sip of your beer, man. Have a sip of your beer. I feel bad. You got the most beer here out of all of us, so we.
I'm just thankful that you're giving me the resolution of the 5 items of the quintuple aim, so I'm going to track down Rob right after this.
Well, only part of it was his fault.
I mean,
he planted some seeds, and then I might have went a little too far because I started doing my research and getting quite curious.
In particular, this next question I think is actually, or next topic I should say.
This next topic is
really
huge. Yeah. So I mean, and like again, one thing I know. I mean, again, I have a few close friends that are in the health care world, right? Burnout. COVID, oh my dear God. Like, I mean, there was never a sadder time to see, how much the system was strained when people were being forced to work beyond 12 hours and beyond 24 hours, I think, in some crazy circumstances. It was insane. And as a result, I think we lost people. We lost people from that industry forever, right? And some people, ended up having, mental health crises and everything else you could think of, right? And that's really unfortunate. What do you think is the way out on that? How do we get better in those areas
fix morale and burnout
for burnout, morale in this industry that's so demanding?
I think for me, first responders have the solution. For transparency, I was in New York during 9/11 at Ground Zero for the first 16 hours.
Yeah.
And one of the questions was, you must have had some significant injury from it. No. And the reason being is that people that I was traveling with, one was a paramedic, a primary care paramedic. Her name was Stephanie. And she was my research coordinator that I was working with when I was in New York City. And I learned from her this whole idea of diffusing, debriefing, and normalizing, okay, that wasn't right. And doing that while things were really fresh kind of set things in motion. Again, that was 2001. 24 years later, I'm still learning from our first responders. And there's a simple thing, which when we talk about operational stress injury, that can then over time lead to burnout and injury and that type of stuff, permanent injury. Normalizing that whole conversation. And the whole program, Road to Mental Readiness, is using some simple words, like, are you green? You kind of normalize this language. And I remember there'd be times...
What does "are you green" mean? Like new?
So green means that things are okay. You're having you're functioning normally.
Are you good kind of thing? Okay.
Then there's yellow, orange, and red. It's a way of kind of normalizing the conversation, saying, okay, the three of us are managing a case in the emerge or in the back of an ambulance or whatever. It's bad. And I'm asking you, say, Matt, are you okay? And you can come back and says, I'll get back to green. It's a way of we're in an unspoken way saying, okay, I'm a little yellow.
Right.
You're not having to unpack things. Personal items are there. But it's in the lexicon. It's in the vernacular. And I think that...
Yeah, you're just kind of checking the temperature of the room, I guess, or the person.
Yeah. So
is the culture permissive of that, you think, though, at this point? Like, everyone's kind of doing that? Because sometimes it's like if, someone asks if you're good, you're like, yeah, I'm good, even if you're going through hell.
Personally, right? I think so. I think paramedics and other first responders, this is in their DNA of helping each other.
Cool.
Personally, I think it all falls apart when you get to hospital. that I think there's a lot of things that we can learn in hospital that we're not doing that could be learned from that theater, which is the out-of-hospital environment. So at the end of the day, defusing, debriefing, speaking about it, I think is healthier. And I'm really proud of my paramedic colleagues for showing me a way to keep me healthy. Again, being the youngest of 6, a husband of 1, a father of 2, in a way which I was able to protect my family. And I think the next steps is still coming from more lessons to be learned from our paramedic colleagues.
Yeah.
So next is, how do we afford it all? But I mean, like, seriously, like, we have obviously a finite amount of funds, and in the last couple of years, we've seen at least provincially, we've seen a government that has invested heavily in the.
Well, none of us want to be paying more taxes right now. We're all stressed. I mean, we all see the financial pinch probably more than ever.
Yes, but we've seen some major investments in healthcare in the last 2 years, and I mean, where are you seeing that we could see some efficiencies, where we can change some things?
A great question. EMS motorcycles. I'm kidding.
Best response.
Best I could do is mopeds.
That's right.
Best I can do is mopeds.
EMS scooters. Yeah.
So I'll give you an illustration that is probably best tries this. Someone has a heart attack. They have a blockage in their artery. We can give a medication to them, which is really expensive. It's called tenecteplase, or TNK. It's a clot buster. And it used to be only given by academic cardiologists and academic centers. Not TNK. It was a previous version called TPA and streptokinase. But these clot busters. It was time sensitive, time is muscle when someone has a heart attack. It then went from cardiologists to emergency departments, but only academic emergency departments, not all emergency departments. And then it went from all emergency departments to saying, well, how could we actually reduce the time to treatment? If time is muscle, maybe that same medication could get in the back of the ambulance. And that's why I started doing research on it in Edmonton when I was doing an epidemiologist emerge. And what drew me to Nova Scotia was the notion is maybe we can give in the back of the ambulance. Now, when you give these clot busters, it doesn't mean that they're then getting them again in the emergency department. You're shifting that medication and the cost with it upstream to when there's that first medical contact at the back of the ambulance. And if you do that earlier, you save more lives, patients do better, there's cost savings with it.
Right.
So I think there's a number of things that we can do without putting new dollars in. It's just, okay, now we need to start doing that same thing for other diseases. Pre-hospital antibiotics for sepsis.
Yeah.
Doesn't mean
do
they
you
get
feel
more.
like government's listening to doctors and medical professionals when you're trying to give this information forward about how we can make things better?
100%, but that's the beauty of the EHS EMC partnership, of EHS being a public utility model. It's one of the most efficient methods of EMS system design. And again, it goes thanks to Ron Stewart and Mike Murphy and Ed Kane that kind of helped create this. Because if you create healthcare in a high-performance system like this, that introduces, as one of the main pillars of it, is economic efficiency. That it's an efficient way of doing things because of the improved mortality and morbidity of patients. So yeah, I don't think it means new dollars. It just means investing existing dollars into these new pathways. And a lot of it is shifting things. So in Nova Scotia, our formulary, our drug box, has almost 50 medications in it, 50. Whereas most EMS agencies have maybe a dozen.
Wow.
So for me, and I
That's
think
good. That's really good.
Yeah. And there's things there, but again, this doesn't mean cost duplication. It means we're just shifting some of those treatments to the back of the first point of care. That it isn't again, your care beginning when you arrive in the emergency department. The emergency department care begins kind of when you're calling 911.
Even the integration of stuff in drugstores, like now you can go there for strep throat. And
Oh, that was amazing.
Last time I had strep throat, I think last year, I called,
Same
I
for
did
my
it on my
wife.
phone, showed
Yeah.
my throat, and he gave me the medication, picked it up. Brilliant. I'm like, thank goodness I didn't have to see anybody for this, right? Because, I knew what it was. My partner knew what it was.
You had a man cold. Those things are terrible.
100%. Yeah. So, I mean, thank you for surviving through that. I appreciate it. The hard part's over. We had a fun kind of bonus prompt here. If you were asked to pick of a pillar in Nova Scotia, which is behind, or if you didn't want to do that, or a pillar that you'd say we're not even looking here and we should be looking there also, either or, what would you say? What would you pick? What would you say that is something that we should be doing better, or we're not looking at? However you want to answer that.
That's a great question. A pillar for me is the whole community health and population health of a community. I think that is the direction that EMS is heading towards. People think EMS is the word that people use. I think it's less emergency, more medicine, and definitely services.
Okay.
So this whole idea is that we're not just taking care of a patient.
Sorry. Yeah.
We're taking care of communities. And I think that is the direction we're heading.
Okay.
I think that's where EMS, the challenge is being given to us more broadly. But I think that is that ongoing new pillar that we're kind of creating. But we need the Nova Scotians' help to consider that, to say,
Fantastic
okay,
answer, yeah.
yeah, it's one that, again, begins with people understanding if you call 911, it doesn't mean an ambulance transport to emerge. It can be something different, and how we get there, we do that shoulder to shoulder with them.
You know, I mean, you answered a lot of, I mean, I'm looking through some of my other stuff here, and we actually, Matt, went through a lot of this stuff, I mean, right up until about the 50-minute mark that I had here scheduled. So, I mean, and plus, I want to get into our fun, dumb questions, because that's the best part of this show, is when we ask you questions that really don't mean anything. They're
I'm
just
all
silly.
over that.
And then just before we get into that, I think
But,
I do the
yeah.
tech stuff.
Yeah, sure.
Let's yeah, I think we should cover off some of the tech.
So the last bit, I mean, okay, well, there's two things. I have a compliment in. I'm going to go way back up to that here. I tell you, I got a lot of stuff here on you, man, because I was nervous for this one. I didn't want to mess this up. You know, my buddy Rob and Andrea, I would have got in trouble if I didn't do a good job here at Toss.
On top of that, it's a topic that we, us dummies don't know anything about.
It's something we don't know. We knew embarrassing little about, so I kind of
Yeah.
over-prepared.
You guys have great insight into it.
Thank you. Yeah. But any of the nurses, this is a compliment to you, any of the nurses working in the IHP program have nothing but great things to say about him and truly love working with him. He is the best, and he's awesome. Direct quotes, LOL.
Oh,
There you go.
I'm
so
lucky.
that was just
Except
a
for the
compliment
card
of you.
tricks, no.
And his card tricks are corny. Oh, I didn't read that one. I thought it was kind of rude. I skipped over that. But yeah. So I guess the last bit that Matt and I we were
Yeah.
talking about this morning. It's something that excites us because I know it's a theme of 2025.
Really is.
Unfortunately, like it or not, AI's here, and seeing how this is going to play into healthcare. I mean, obviously, I think I don't know if you know this, but like just recently, ChatGTP took a step back and basically stopped diagnosing people because too many people were calling in with their ChatGTP diagnosis, thinking that they had
Dr.
issues.
Google.
Going in and seeing it, and it's like I think you were going on about vaccines. I mean, there was if you look deeply enough into ChatGTP, there'll be things like, well, there's cyanide in the vaccines, but when you look at it, that type of cyanide might be different from the type of cyanide that you'd be extremely concerned about, or a different chemical element. But anyway, so it's obviously having its challenges now because it's, as it provides us a generous amount of great information, there's a lot of misinterpreted information and misinformation. Like, how do you see this playing a role in the next few years to come? Are you looking at it closely?
Yeah, and it's already here. So I'm proud that that our system is incorporating AI into the communication center, so that we're able to move patients more efficiently and recognizing patterns and that type of stuff. So as opposed to relying upon just a person kind of listening and saying, okay, we're going to match this resource to that patient's need, having some of those AI tools in the background can make it a bit more efficient. There's other items there too where AI can be helpful right at the coal face during the 911 call, where a person's answering questions, but there's something, a signal in the noise as the person's speaking, that AI can be used saying, the person said they weren't short of breath, but we picked up on
But you're
the
feeling
person.
it, you're hearing it.
You can hear it, exactly.
Right.
And it's not to replace that human judgment, but just to kind of put an alert on it. They said no to the key directed questions, these closed-ended questions that the dispatcher or the call taker is using, but AI is is kind of picking that up in the background and saying, okay, it's a discordant finding, a bit of an alert that comes up.
Right.
Again, not to override the decision, but as an aid to it. And you guys, and the cool thing too, just to show you where the technology is, the phones have a thing, the way they sample from top to bottom, it can pick up subtle variations imperceptible to the human eye. So the tool that I was talking about with Good Sam Video,
Right.
when we do that with patients, you can click a feature. When I'm talking to them, their heart rate appears next to their image. I'm not even touching them
Well,
Wow.
because it's recognizing the oscillations in the person's color.
When do we get robot doctors? Is that
Drones.
yeah, there you go. Right? Yeah.
But that technology is there, and we were just getting back from Denmark, and in Denmark they were using that technology during the 911 call taking process for people that were in cardiac arrest, and saying, look, I think you should start chest compressions to the caller. Based on what you're saying, I think the person doesn't have a pulse. And the person's like, well, I think they're breathing. No, those are what we call agonal respirations. We want you to start chest compressions. And the person's like, no, I can't. In Copenhagen, they were doing research on it where they can send a link to your phone, hold your phone over top of the patient, and that is able to determine if there's any kind of pulsatile blood flow.
Wow.
And with
Holy
that,
smokes.
they can say, okay,
Wow.
no, I can tell you there's no blood flow there, start chest compressions, and they would. It improved the accuracy. So the technology side of things, whether AI or it's the software or the apps, I think we've got an obligation of matching that tech to the patient's needs in a positive way.
I can ask you a weird, more philosophical question on
Yes.
this. So here's a challenge. So we use this technology, and we've all medically got to this point where we're at here now in life, in society. I mean, do you have any fear that the research would stop? Like we want to keep going? Like, so if we start relying on AI heavily enough that,
No,
That's a good question.
we
Yeah.
not,
I think you can't beat human conversation.
yeah.
There's tones there. You can tell that there's a soul on the other end of the phone on both ends. And people help people. And I don't think AI can do that. And I think that whether it's by phone or video or on site, humans are still going to be here.
So that deeper human level and intuition still kind of going to override certain things, certain feelings, no matter what.
Yeah,
Yeah.
humans will have a gut impression. And that gut impression speaks volumes.
No, I believe that, 100%.
Like that rake outside in the hallway that you walked into saying, I knew I shouldn't have gone that route.
All right.
Anyways,
Do we want to move to 10
well,
questions?
I think it's time we move on to our 10
Let's
questions.
do
my
10
friend.
questions. So this is
Yeah.
a fun little
Yeah.
game. We kind of throw some semi-rapid fire, right? Here, I'll kick it off with number 1. So welcome to 10 questions. Here we go. Question number 1. If an ambulance call had a theme song, what do you think it would be?
Theme song. The James Bond intro theme.
Oh, okay. Like Goldeneye kind of thing?
No, like that ding 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 ding
Yeah,
ding
okay.
ding 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 ding.
All right.
Ding ding ding.
I like it.
Yeah,
Yeah.
I think it.
I thought it'd be a little more punk rock personally, but I still like it. Yeah, like, dun, 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 kind of like.
I personally, if you want people's attention, I think it should be like immigrant song.
That was just playing as the sirens are going. That'd be pretty
when the
awesome.
sirens are going, it's just,
Yeah. That'd be pretty cool. Okay, if you could add one fun or ridiculous feature to every emergency room in Nova Scotia, what would it be?
Doodle boards.
Doodle boards.
Yeah, every patient service should have a doodle thing so you can doodle on it, and that stuff. I think it should have that.
That's great.
medical etch-a-sketch.
Also for like soft serve ice cream, like you just be like, oh, get a little sundae while you're there, while you wait.
I certainly would take that. All right, question number 3. In an alternate reality where you were a musician instead of a physician, what would your instrument of choice be?
Drums.
Oh, that was
Cool.
quick. You
Do you
had that
play
loaded.
drums now?
Air drums, which I suck at.
Right.
Yeah, it'd be drums. I love percussion. The drums.
All right, cool. Question number 4 for you.
What's one thing that you think all people should have in their home to help them in a medical emergency that most people do not have?
That they don't have.
So think of something that you should have in your home in case of a medical emergency that you may not have. Or if
No, maybe it's like a metal straw for a tracheotomy or something.
Gross. Or we could solve that up. Maybe something that's advisable to have to avoid a trip to the ER, like to check blood pressure or anything like that. Is anything of those things really great to have in the home, like a blood pressure cuff or a
good tweezer.
good set
Good
of tweezers?
Yeah.
You know what?
Good tweezers is a good everyday carry item. Have it in the kit available. The Lee Valley one that actually is like on a keychain, that is a guaranteed win.
Can't
for
sleep
people
on a good
to
set of tweezers. I agree.
Good
we
set
have
of
like
tweezers.
4 or 5 tweezers, and there's only one I'll use.
Oh yeah.
Yeah.
We have quite a few tweezers too. I live with 2 girls.
Really
so
good
lots of
tweezers.
Yeah.
I'm sorry that took so long.
No,
No,
that's a great
that's
answer.
great.
Yeah,
It's a great
no
answer.
worries.
No, you were
Right.
reaching for the defibrillator because I took so long to answer that.
All right, question number
Literally.
5.
Yeah.
What's one of the most bizarre things that you have seen in the ER that you can legally tell us?
A moose foot in someone's abdomen brought in as a major trauma.
Whoa! Like the
I'm thinking car
foot
accident.
was stuck in there, and the rest of the
Yeah.
moose was gone.
I'm thinking car accident.
Yeah.
So yeah.
Yep. So
Oh,
Wow.
so what they do? They sawed off the moose foot
no,
leg.
no. The patient did well and
Yeah.
that type of stuff. But
Oh,
yeah,
good.
a moose foot in someone's abdomen.
Wow. Okay.
Got to get my moose by.
Number 6 over to you, man.
All right.
Jeez. Holy.
If you could watch one last movie from all the shows you've seen in your lifetime, which one would you pick? I guess we're asking for an all-time favorite film.
Aliens.
Great movie, dude. Yeah, cheers to that.
I can do Aliens karaoke.
Popping.
I can turn the volume off. I got all the lines memorized. I love that movie.
Fantastic movie.
It's Aliens. Yeah, number 2.
Are you watching the new show?
Yes, Alien Earth.
Enjoying it?
I did.
Okay,
I love the Peter
great.
Pan reference.
I got to finish it, but most of the way through.
Okay,
Yeah.
no spoiler.
No.
I loved it.
Yeah.
Aliens.
Fantastic. Yeah.
Question number 7. So we saw one tonight, but what is your favorite card trick that you've ever performed?
My favorite card trick is the next one that I do for my wife.
Oh,
I love her reaction when I do a card trick. She's been married for over 30 years,
Mm-hmm.
and she is I love doing a card trick with her, and that is my next favorite.
I love it. That's a great
Amazing.
answer.
Great answer.
Yeah.
Yeah.
All right, number 8 over to you.
Okay. What is the bad habit, and please don't say beer, that could likely result in the most ER?
You jumped to 9.
What? Did I?
Number
Where
8.
were we at? Oh, sorry.
Yeah.
Okay. I'll finish this one, and then you read it. What's the bad habit that likely results in the most ER visits?
The river disease.
What's the river disease?
Yeah, denial.
Oh, bad joke, bad pun.
The most common thing is people, they don't pay attention.
They're
And
not
it kind of goes
paying
back to the
attention.
conversation before. It's pay attention to your instincts.
Yeah.
I can't say it enough. You know your body, your family around you knows you, and if something's not quite right, seek help.
All right, question number 9. Your likeness has been casted in the ER-based soap opera. Who plays you as the actor?
The fellow who is in Knight's Tale, he's British. He played Chaucer. He does the voice. He was in the Marvel universe. He played the computer guy.
Oh, yeah, okay.
Vision? The guy that
Vision.
played Vision?
Yes.
What's his name? Gosh.
Yeah, he was also in
man.
the what's it called, the Tom Hanks movie there.
Great actor. Paul?
Paul Biemini.
We'll just call him.
Yeah.
Our friend Paul.
Yeah.
Yeah, he's a fellow albino.
Are you albino?
No, I just
No?
like it.
And the last question.
All right.
I like to say,
Matt, you wrote this in.
I did.
Can you take a look at the mole on my back?
there's too much hair there.
Yeah.
You can't make it through the hair.
Okay, so this was really funny today. He sent me over these 10 questions, and all he had for question 10 was when.
Oh, did I not finish
That's
it?
No, it was just when.
Oh, geez.
So I
I
was
probably
like-
just sent
So I'm going to finish that, and I was like, you know what? I'm going to start this. I'm going to make him ask that question. And
You did a
Check
perfect job. Yeah, good job. That was a
There you
great 10th question.
But, last call.
Yes.
So we have a last call, which is where we ask you for advice that you were given in your lifetime that you would like to share with us and our listeners.
Just stay connected with family.
Okay.
It's
Stay
the
connected.
that's my advice to my kids, to my family, to my friends, my colleagues, people that are important to me. Is just stay connected with your family. You can't beat it.
Great answer.
That's awesome.
Thank you so much for your time.
Thanks.
We really
Cheers,
enjoyed
fellas.
this. We learned a ton. You're welcome to come back anytime you want to talk about any issue. We would definitely welcome a second round in the new year. Thanks again.
Awesome.
Thank you, folks. Stay well.